Lower limb amputees are at a higher risk of falls than the general population. Every amputee should ideally have a plan of action and know their ability to get up from the floor should they have a fall. If they have trialled various techniques with the supervision of therapists and a safe way of transferring cannot be found, then they should be advised to call for assistance instead. A personal alarm is highly recommended in this circumstance. Where possible, prior to discharge from hospital, all new amputees should have practiced getting up from the floor with the treating physiotherapist. If required, further practice can then be factored into their rehabilitation program as an inpatient and/or outpatient. If you are unsure about your patient's physical capabilities with relation to a floor transfer, a good place to begin practice is on a treatment plinth. The patient can then safely practice getting into a 3 or 4 point kneeling position. Knowing whether or not your patient can achieve this position will help determine the most appropriate method for a floor transfer. Beginning with a transfer to a low plinth is generally advised. You can then gradually raise the height of the plinth and test your patient's capabilities. Ideally, they should also practice a transfer directly onto their wheelchair in case they have a fall when out in the community. Getting onto the floor. In order to practice getting up from the floor, you need to be able to safely get your patient onto the floor. An exercise mat should be placed on the floor for safety and comfort. A large plinth which can be lowered close to the floor is also ideal. With the plinth at its lowest height, most patients find it easiest to ease themselves onto the floor from a prone position, lowering legs over the edge first onto one or both knees. Getting into kneeling. This can be done via prone or via side lying as shown. As mentioned, practice this on a plinth first. Below knee without prosthesis, backwards. If your patient cannot get into kneeling but has sufficient range and strength in their shoulders, they can transfer backwards as shown. They will likely need 1 or 2 steps to gradually come up. Below knee without prosthesis, front on. Most below knee amputees find it very uncomfortable to kneel with their rigid removable dressing on, so if it is safe to do so from a wound perspective, you can advise them to take it off for the transfer up. The technique shown is generally the easiest way of transferring via kneeling, but it requires a large surface to transfer onto, ideally a low bed or sofa. This technique would not be suitable to transfer directly to a wheelchair. The patient should get as much of their upper body as possible onto the bed prior to attempting the transfer. If they have sufficient hip range, they can lift their residual knee onto the bed for stability and assistance. Instruct the patient to tuck their sound toes underneath to allow the calf muscles to assist the upper body with propulsion onto the bed. Below knee without prosthesis, side on via kneeling. The sound hip should be positioned closest to the plinth. With this technique, the patient can avoid having to stand all the way up. Below knee without prosthesis, front on via kneeling. If transferring directly to a wheelchair, the patient should be advised to make sure the brakes are firmly applied and the foot plates and stump support are well out of the way. If help is available, advise your patient to get the helper to steady the chair. These techniques can all be used with a below-knee prosthesis as well. If your patient is a new prosthetic user, check that they can do the transfer with their prosthesis. At times, the prosthesis can become loose during the fall itself or during the transfer. Ensure your patient is aware of this safety risk and checks the prosthetic fit prior to putting weight through it. Above knee without prosthesis, backwards with step. Similar to below knees, if an above knee amputee is unable to kneel on their remaining knee, then they may have to utilise a step and transfer up backwards. Above knee without prosthesis, front on via kneeling. As for below knees, this technique generally requires a large and low surface to transfer onto, like a bed or sofa. If the suture line has healed well and the patient has sufficient hip range, they can lift their residual limb onto the bed or sofa. They otherwise perform the transfer just like a below knee. Above knee without prosthesis, front on via standing. More often than not, patients do not have sufficient hip range to place their residual limb up onto a wheelchair cushion. With sufficient upper body and sound limb strength, the patient can push directly up into standing. Above knee with prosthesis, front on to wheelchair. Most above knee prosthetic users can tolerate kneeling on their prosthetic limb. This allows a transition from 2-point kneeling into half kneeling with the sound limb in front. Pushing with the sound limb and upper body, the patient rises into standing. The patient needs to be careful to lock the prosthetic knee. Above knee with prosthesis, no assistance. This technique has the highest level of difficulty but is most useful, particularly for patients who are active in the community and walking unaided. Below knee prosthetic users can also use this technique or rise up via kneeling. Bilateral amputee without prosthesis, front on via kneeling. A bilateral below knee amputee can use the same front on kneeling technique as for a single amputee, providing they have sufficient hip range to get a knee onto the supporting surface. Without any pusher from the calf, however, more upper body strength will be required.